I'm David Jones. I'm going to be telling you about eye disease over the next few minutes, but I would strongly recommend that you visit my YouTube channel under the name Dilate, which has a lot more detail about retinal diseases, cataracts, glaucoma, examining the retinal afferent pupillary defect, and an example of cataract surgery. And just look for my YouTube name, which is Dilate. So why can't people see? Because that's the main reason why ophthalmology patients come to us as doctors. Well, there are three main reasons. The first is that the eye is not acting as a lens system properly, so there's a refractive error. Sometimes that lens system is cloudy for some reason or another, be it the cornea at the front here, or the lens in the middle here, or the vitreous humour towards the back. Sometimes it's the fact that phototransduction, whereby light is converted to electricity, is not working because there's a problem with the retina or the optic nerve itself. And of course, that signal needs to reach consciousness somehow, and if the brain is not working, then we may not be conscious of what is otherwise reaching the brain in good condition. So let's start talking about refractive error. That's a disorder of focusing. Very briefly, we all know that refractive error is common and can present as myopia, hyperopia, and astigmatism, all of which we can leave for another day. Presbyopia is completely different though. Presbyopia is the lack of ability to change focus from distance up to near. And whether you are short-sighted or long-sighted or have astigmatism, everybody is unable to focus up close after about the age of 50 or so, and that's why we need to wear reading glasses. And I must emphasize you mustn't get that confused with refractive error, which is a fixed short-sightedness or long-sightedness. So let's talk about media opacification. At the front of the eye, we've got the cornea. The cornea can be clouded due to infection, and this is an example of a nasty microbial keratitis. It can be caused by an inherited corneal dystrophy, whereby the natural collagen fibers are not crystal clear and not laid out in a perfectly crystalline array, such that they are cloudy. Sometimes, although the crystalline nature is still there, the shape of the cornea is abnormal, such as this keratoconus, where the cornea is in a more of a teardrop configuration. Sometimes the eye can be incised or lacerated, and that also can cause corneal clouding. The treatment for corneal clouding is often in the form of a corneal transplant, whereby a donor cornea from people such as yourselves can be sutured into a recipient eye, and is a major reason why you should seriously consider donating all your organs for transplantation, and do not exclude eyes. Next, we go to the middle of the eye, and we can talk about cataracts. Any clouding of the lens in the middle of the eye is called cataract. There are lots of causes of cataract, and we don't really need to go into it in too much detail. And of course, there are lots of different morphology of lens clouding, and you can see 4 here if you look at it with the microscope, the biomicroscope. But if you want to know any more about cataracts, then there's a 10-minute cataract masterclass that I've done. You can find it on my YouTube channel, but you can also find it through the UEMS YouTube channel. The treatment for cataract surgery is always surgical, and that means addressing the needs and fears and concerns, and addressing the risk aversion of your patients, and then doing the surgery. If you want to find out more about the surgery, you can either look at my cataract masterclass, or I've got a full 6-minute summary of how we do cataract surgery from beginning to end. Next, we can go on to phototransduction disorders. That's a disorder of the retina that is no longer converting light into electricity. So retinal diseases are a very big group of diseases, but include macular degeneration, retinal vascular diseases, and detached retina. That's a physical detachment of the retina from the back of the eye. There are also inherited retinal diseases, just as there are inherited corneal diseases. If you want to know more about it, go to my masterclass on retinal diseases. But very briefly, macular degeneration is a very common cause of vision impairment in the Western world, particularly in the over 60s, and is increasing in the Third World. It causes loss of central vision, but retention of peripheral vision. It can be divided into dry and wet macular degeneration. Dry macular degeneration is the commonest cause of legal blindness in the over 60s and accounts for the vast majority of macular degeneration. It is characterized clinically by thinning of the retina and pigmentation with deposition of waste products of metabolism called drusen. It tends to run a better prognosis than wet macular degeneration, and that's because it progresses very slowly and gives the patient time to get used to their visual impairment. So here we see the drusen. These are the white dots replacing the normal orange pigment of the retina. And if we do a fluorescein angiogram, we can see these dots start to fill with fluorescein and fluoresce. By contrast, wet macular degeneration is a rarer form of macular degeneration, but can result in more severe visual loss, whereby new blood vessels grow from one of the deeper layers of the retina and can suddenly break off and bleed. Here is a tangle of new blood vessels about to bleed. Here it has having bled underneath the macula. And if we perform a fluorescein angiogram, we can see that tangle of blood vessels that's about to burst through the retina. There's no satisfactory treatment for most macular degeneration. There is some weak scientific evidence to suggest that dietary supplements, particularly in beta-carotene, can help. Avoiding smoking can reduce the risk. Sometimes laser treatment and photodynamic therapy can be used, but that's much less common these days. In wet macular degeneration, we can inject anti-VEGF, that's vascular-derived endothelial growth factor agents, into the eye every month for a few months, and that can sometimes arrest or reverse the development of wet macular degeneration only. It took some time to get this rather expensive and repetitive treatment accepted, but eventually it was approved 12 years ago and is now in common but very expensive use in the health service. Secondary prevention of further disease to, for instance, the other eye includes checking the vision on an Amsler chart. This is an Amsler chart. You can print one off the internet. You can ask a patient to look at the dot in the middle and to tell you whether the lines round about are present and correct or whether they're blurred or distorted. And that's a good sign, early sign of macular disease. See more about that on my YouTube masterclass. And then, of course, we all need to be proper supportive doctors by signposting our patients to low vision aids and possibly registering them as visually impaired. It's important to counsel our patients that they are never going to lose their peripheral vision. They're not going to become black blind. But patients who have lost significant amount of vision can suffer from visual hallucinations called Charles Bonnet syndrome. Next, we're going to go on to diabetic retinopathy.